This is, I just happened to have seen quite a lot of Olecranon Burseas in the last few
Okay.
days. And so I thought I would share some pictures of that. And that
John,
is,
what is the debris inside of that synovial fluid, or is that even synovial fluid?
it will be synovial fluid of some sort, yes. And they've got their debris, fat. The fat, you get flat globules,
Okay.
hypertrophy with chronic inflammation. But that's not an unusual appearance. And I probably wouldn't be showing you these, except that there's been some different stuff.
You've had a rush of them, and so there must be, the gods are saying, share this with Fritz.
Yeah.
Wow, wait, I love this. That is what they call a ground glass appearance, and usually indicates blood or some form of complex fluid. Is that right?
Yeah. So I've described that as a blood-filled Olecranon Bursea.
All this kind of stuff I want to see, John. I'm hungry to see that kind of stuff.
And let me just check. I think this may be, yeah, that's the same one.
That's okay. I want to see the eddies in the stuff when you're pushing around on it.
Yeah.
Do you drain this? Is that what you did, or?
I wouldn't know, not in an Olecranon Bursea, no. They are very prone to infection if you stick a needle in. Some studies show anything up to 1 in 10, which is a very high. Usually, the series that have been looked at that have looked at that and got those sort of figures have involved a steroid injection as well, but it's still a very high number. So
why? Just dirty elbows, or
probably that. I'm guessing, but one of the arguments is the skin is particularly hard to clean around the elbow, and it fits because the other place that the surgeons really have difficulty controlling their complication rate is around the Achilles, where the skin is also, that the skin tends to be dry, tends to be wrinkled, and another area that is considered a very difficult piece of skin to go through. And so that's that Olecranon Bursea. This one is one that's associated with gout, is what I put in the notes. Now I'm going to show you one in a moment, which is very much more.
John, the telltale that made you say gout, does it have to do with, let's say, what looks like stars floating around, or the twinklies?
No, not in this case, but we'll come to that. In this case, it was just that the patient had gout, and someone had aspirated it, not me, and found crystals in there, and so it was associated with gout. This is just a normal. This is very normal appearance for a chronic Olecranon Bursea, and you just see the thickening of the lining there as we go through. Just the this.
John, can you pause it and show me what you would call the thickness, or what would represent the base of the synovial lining? Where would you? Because to say thickening.
I'm thinking this layer here.
Okay.
And also this layer here, but you'll see that a couple in one I'm going to show you in a minute. And just let me pack through this. I think sometimes my device. Yeah, there we go. If we wind back, that's a classic appearance there of the mildly edematous synovial lining. There, do you see it?
Yes.
Yeah. So the double lines there, the walls going round like this, and that's a relatively. I put it down as chronic, and it will be chronic, but that's what you see in just a a relatively low grade bursitis. You know, that's
the tissue below the bursa. That
yeah.
is actually the tricept, or is that just
No, the triceps will be here,
okay?
and this will be fatty tissue,
Okay, all right.
which is often reacts and becomes bright and hypertrophied and enlarged in that situation. This is a big one.
Whoa! Give me a type of food, or help me understand how viscous that is that I'm looking at. Are we talking Jello? Are we talking like beef broth, or what is
You
it?
cannot tell. You cannot tell from the images. It doesn't give you a clue. You could argue that this has got to be quite a lot of protein and not water. This will be some sort of, you know, whether blood products or something like that. But in terms of the actual thickness of it, the thickest stuff you ever get out is what you get out of a ganglion, and they are clear. So they're not very. You don't see the content of a ganglion normally. It's just clear, and yet those are massive chains. They're like 1,000 atoms long. The hyaluronic acid chains in a ganglion, and so it isn't. You really can't tell. I don't do a lot of aspirating of abscesses these days, so I don't do this sort of thing in hospital environment. But when we did, you couldn't tell the difference. If it could be clear, and it could be pus, and it could be really murky, and it could come out a bit watery and not very exciting. So you don't necessarily get a clue from the content. It is telling you, I'm sure it's telling you something, but it's not telling you what you would expect it to tell you.
My eyes want to see things swirling around and creating eddies if it does not have, you know, an aggressive viscosity. This looks more like this looks like a big blubber, you know.
It could almost be a solid mass with that.
Yeah, soft solid mass, right?
That sort of thing.
Yeah.
It could almost be a solid low echo, even quite serious mass, which is why when you see that, you have to take the time and check the color and not jump to conclusions.
Meaning color Doppler to check the metabolics of what's going on there.
Yes.
Wow.
Slightly more acute, so a little bit more. They don't often come to, you know, some people wait 4 or 5 months to get scanned in our environment. So I don't see that many acute ones of these, but that's the sort of more interesting color flow you'd expect to see with that.
And that looks as though it's at the interface between the vault and the actual bone.
Yes. Yeah. So tracking along. Yeah, but a little bit going on, not a huge amount. This was one that had got better. You know, they turned up because they'd waited so long, and it had settled down, and that's all you see. So you still see the lining there.
Oh, sure.
But it's collapsed down. And this was a guy who thought it had gone away. You know, it wasn't that it was just feeling better. That was he thought it had gone. But you still see the walls of the bursa, but just nothing in it. I think this one we've seen before, and the way I've searched for it, that's an old one.
Old as in you and I had seen it, or as
we've seen it. No, I've done the search, and it's come up more than once. The same scans come up more than once in the search. Resolving. There was one simple solving. Right. This one was the one I wanted to show you, almost as a final hurrah. This is one of those scans where I started scanning and I thought, I don't know what's going on here. And I couldn't see what you normally see. I couldn't see the bone at all. And it's because this layer here is really strongly absorbing the sound. And so you think, I've forgotten how to scan.
Let me try to restate what my mind is thinking you're saying. Your eyes will just have, as part of identifying where you are, the brightness of the bone below. And when you started doing this scan, you didn't have the orientation of the topography that you're used to seeing below. And then your mind went to, why is it not resolved as brightly? And you said it has to go through a bunch of dense crud, and so we're not getting that echo contrast.
Yeah. When you look at any collection of fluid, one thing you expect to see is that everything underneath it is going to be brighter
because it's enhanced. As my understanding, physics-wise, says it's going faster, and somehow it gets a brighter bounce to it, or why does it?
It's not going faster. The normal tissue absorbs the sound at a certain rate.
Yes.
Yeah. And fluid, because there are no boundaries in it, in part, very homogeneous, it carries the sound much more clearly. And so the volume of the sound going in your pulse does not deteriorate with depth in the same way that it does going through normal tissue. So normal tissue, the sound waves get weaker and weaker and weaker, and that your machine has to compensate for that by amplifying them more and more and more. When you get when it goes through fluid, it doesn't go through significantly faster, probably slightly slower, but what it does do is more of the sound goes through. So everything deep to it looks brighter rather than darker. So when you scan something like this, you then have the question, well, I can see that that's fluid. So why is everything behind it darker rather than brighter?
I got all of that, John, including the clarification that sound goes at a certain speed, Fritz. It can't speed up halfway through its journey to the bone.
It can, but it depends on the content. And I used to know the different speeds through different tissues. I've forgotten them.
But there's an assumption for normal tissue that a certain depth has the computer processing, this is what we should be seeing. And if it goes through fluid and it has not attenuated or reduced, it's going to bounce back brighter, at least in the picture.
Yeah.
All right.
Yeah. And that's what you get. And immediately you don't know that. And so I'm looking at this thinking that wall there must therefore be really dense, even though it's relatively bright. Wow. It must be bright and dense.
What you're sharing is so powerful. Once I get my head around what you're saying, is you've immediately thought, why am I not seeing stuff down below? And your mind went to the fact that there is something up at the top that's doing that. So what is it?
Well, it's this patient had untreated gout. So he's got so he'll have crystal deposition within the soft tissues, sort of what they sometimes refer to as tophus. But this will be more diffuse than the usual collections of it.
And it will be a shield against the energy or the sound getting through it. Interesting.
You see, and you see that to a certain extent. I think I'll maybe showing you a case later if it comes up as I go through, where we're looking at calcitic tendinosis, and when that's in its soft phase, you get shadowing, but you don't get as solid a shadowing as you do with the hard phase. So the same thing, the signal is lost, but not completely lost going through.
I'll be quiet because I want to get there.
Yeah.
Did you just do a scan for Olecranon in all of your stuff and these all came up, John?
Yeah. It's just.
You are a resource. What is that?
That's a bit of glass.
I was just gonna, it looks like a foreign body to me.
Yeah, that's a piece of that's a piece of windscreen glass. So you know how it shatters into tiny little bits. Well, that's a bit in an Olecranon Bursea.
Wow.
Yeah. Cool. Look.
Very, very cool.
So then where do I go?
How long since injury?
I suspect a while. That was I don't remember the details. Now let me have a little look. I'm just going to stop sharing for a moment, and then we'll get over onto another page.
John, I'm in Vancouver this weekend.
Yeah.
I am 3 days scanning with naturopaths who are learning regenerative medicine. So they're doing prolo, PRP, stem cells, hyaluronic acid, and they've invited me because they know I haven't a clue how to inject anything. And on the last day, it's cadavers, and they're going to let me try my hand at puncturing through capsules and a number of things like that. So it is going to be eye-opening to me as one of the components that I'm feeling particularly deficient in when I work with people in the lab is telling them where to place what, and even the logistics as to how they do it. So, this will be interesting to me. This will be this will be an exposure to what I want to learn from you. What a well-oriented long axis is, and how you keep the needle in view of it. Or do you even care about that anymore because you're more involved in seeing what the tissue does under the ejection of the fluid?
I'm always interested in it's all about scanning is all about getting your planes right. So it's always about being absolutely in long section and short section. That never goes away. That's you can't scan well unless you're doing that. I think you've got to first and foremost is the planes that you're in. Let's have a look. If I go here, now bear with me while I set this up. I should have done this all beforehand. I thought I had, but you know how things go. So if I go first, this is, I'm just going to share again. Works. Good. I'm quite sure you're sharing screen. Yeah. Okay, so subject to Bursa's before we get on to before I find the calcification. This is an interstitial Bursea.
Help me. So an interstitial Bursea means that it is not anatomically, it's a variant, and it has established itself in normal tissue. Is that what that means?
Yeah, that would be my understanding of it. This is under the second toe, under the second MTP joint.
Huh.
So, and these are not uncommon, but they're usually trauma, and often repeated trauma. People who walk a lot, they don't always get Norton's neuromas. Sometimes they just damage the fatty tissue under the metatarsal head.
Wow.
And we try to leave those alone because, again, like the Olecranon Burseas, they do better left alone, we think. And let's see, there was something interesting here.
So you don't introduce any type of anti-inflammatory or corticosteroid. You'll just say, let's protect it by a relief insert and that and stop using it. Quit walking around.
Okay. That's my let's have. I'm just going to copy all these and drag them over. Paste. This should Flexus sheet. This just a little bit anatomy. Tell me if you recognize that just before I
look like the carpal tunnel at first, yeah.
Yeah, and what you get is that that classic anatomical sense that the synovial sheath, there's no synovitis there, here and here, and you're just seeing it around this flexor tendon complex.
Wow.
And this is, but they're all synovitic.
Yes.
And that one there, and you see how the synovial sheaths from the fingers don't reach to the synovium.
Interesting.
To the palm.
Yes.
So there's a synovial sheath that goes to there, and there's a stop, and there's a synovial sheath that goes beyond that.
I did not know that.
So yeah, you kind of always assume that they must all be connected, but they're not. So there you can see the finger flexors go into the palm, the sheaths, and then they stop, and then you've got the carpal tunnel there.
I don't understand the fluid dynamics of that, but that's just my personal problem.
Yes, it is literally just the sheath. It's like the kids, the gloves that are chopped off.
Yes.
Yeah. So the sheath ends in the mid palm from the carpal tunnel, and then they've got a new one that goes down. They've got individual the synovial sheaths are individualized in the fingers.
My mind sees a synovial sheath as a balloon that goes around the long strand collagen of tendons. And my mind sees that balloon as putting a lubricant in the actual fibers, or at least having some type of a way of equalizing pressure from one vault to the next, but it must not. There must be a seal.
Yep. The seal. I've got a good one to show you later, where it's not complete around the tendon either, but that's in the big toe. I don't know whether that's anatomical variant or just an oddity, but that's what we see. Let's see what else is on this list.
Am I seeing the carpal tunnel cover as being wider than usual on that last one as well? It looked like that was. Yes.
I think so. I don't remember the case specifically, but no, that's the wrong one. Let me get synovial sheath. Yeah, flexor sheath synovitis. I think a little bit. I suspect this was a rheumatoid patient, because I think I've got another case here. Probably look at the same thing. This is one of the things I look for specifically when if I'm and alerts me if I see it incidentally for rheumatoid or one of the inflammatory arthropathies.
Or dorsal wrist.
Yes, this is dorsal wrist, and this is the mid-carpal recess over the capitate. So, and when you see this with this sort of bulbous shape, almost like I don't know, an eggplant or something, or courgette shape, when this is swollen, that rings a definite inflammatory bell. You can often see a little bit of inflammation in the wrist joint itself, but when this joint here is shows evidence of inflammation, then I'm definitely interested.
Interested in a global presentation of an inflammatory process.
Yes.
Yeah. Okay.
Yeah. It's for me. It makes me. And this patient was on prednisolone already for PMR. But they still had active disease there, and so we
that's the
highlighted.
capitate in the bottom left, that peanut shape.
Yes, yeah. So yes, that was all interesting. Now let me see see if I can find. Yeah. So. I get rid of all this. Hang on, I'm just going to see if I can tidy things up, and things will go quicker.
Where are my little friends? Are they all at their Boy Scout, Girl Scout like stuff?
Yep. Yeah. Well, two of them there. Beth should be doing some homework. She very much appreciated the trip to Starbucks.
Oh, good. I'm glad. Do you have one near home?
Well, we got one in the town, so they went there. They were chuffed to bits when they said, "Yes, we take dollars."
Oh, I didn't even know it came across as dollars.
Yeah. Yeah. That's all right. They take both kinds.
Now this is shoulder.
Yep.
And we're whoa.
So I think this is for me, it's something I look for specifically.
You say it is something or is not something?
It is something I look for.
Talk me through it
specifically. So when
long
I'm coming
head of the biceps.
Yeah, but I'm in long section. So I'm in essentially in my view for looking at supraspinatus.
Okay.
So long head of biceps should be almost in long section.
Yes.
When I get there, because it just kind of trickles under the supraspinatus as it goes into the joint.
Yes.
So it's just slightly oblique, and then as we go through, you see there's material here at the insertion. So initially, I'm wondering what's going on because it doesn't look normal, and then there you see the tear. So this is torn not at the insertion, but just proximal to it, which is for us at least is a much less common.
So hold that right there for just a second. In a cross section of the interval view, in one of those, one of those anatomical studies that came out, this seems like the location where they're indicating the coracohumeral ligament, the sling part between the long head of the biceps and the anterior fibers of the supraspinatus tendon exists, at least according to that slice, as they're talking about the sling. So I'm listening.
So where that is will be around this part. That all happens very, very close to the biceps.
Okay.
So we're seeing it above here.
Okay.
We're past that.
And would you say you would call this then anterior supraspinatus?
That's anterior supraspinatus.
Okay.
And we come across and that's carrying on going. So that tear there, that proximal tear is full thickness, and it's going all the way across the supraspinatus. And now you've got some material coming through. You see this piece here?
Yes.
This is infraspinatus, and I recognize that because of the angle it's going at.
Wow.
You see how it's
yes, I do, and it's your eyes that know where it should be, and the angle that because you know you're oblique on those fibers as you're sliding from supraspinatus.
Yeah, because and that's why it's so important to be bang in the right plane for supraspinatus.
Yes.
Because then when you see that effect, you can be confident that this is the the upper part of infraspinatus, and it's
Yes.
coming across. And so you can tell the whole of supraspinatus is gone because it's all gone from there.
Wait a minute. You would normally expect that the infraspinatus would lay over the top of some of the supraspinatus,
Yeah.
and since all the fibers are oblique here, you can know that the footprint has been totally pulled off.
Yeah, there. This bit here,
Wow.
there's no supraspinatus under there.
Yeah. Wow.
So the fibers that I'm looking at there, the bits that are intact, in that
Yes.
section, are not supraspinatus.
Take me back again. Oh, you are. Go ahead.
Yeah, just there. So you see, you've got your infraspinatus fibers are resting on the cartilage at that point.
Yes.
So that means that there is no supraspinatus. So we've either gone past the footprint of supraspinatus, which is actually probably up here, which may well be the case. But it does mean that your tear, as you're still seeing tear here, and you're seeing infraspinatus resting down onto the cartilage, you know the whole of supraspinatus is gone. For what it's worth.
Wow.
Yeah.
This you knew exclusively from sweeping the probe in a long axis or long section on rotator cuff.
Yeah.
I see it.
Yeah.
That's impressive.
So it was just, you get this when there's a bit of fluid, you get some nice anatomical delineation of these tears. But
The white, the bright stuff to the left, where I would expect muscle or whatever to the left, is that fat?
Yeah.
What is that?
I presume I'm presuming so. But yes, it's nothing else. It might be some sort of granulomatous tissue, but most likely it's just reactive fat changes in the fat.
All right.
So yeah, I thought that was quite a good descriptive scan.
That is phenomenal.
Let's have a look. All right, I think we've seen that one. Sorry, I'm just remembering what date I saw you last time, so I'm just making sure that I'm not showing you stuff
No.
that you've seen before.
That's assuming my mind has the ability to say, "Oh yeah, I've gone through half of episodes that I know I've seen before and gone, huh." On shows.
Yeah. Let's see. This is something I do not see very often. That's not even true. I don't think I can remember seeing this before. That's calcification within the ulnar collateral ligament of the elbow. Thickening of the thing and some calcification there. And I can't really tell you anything about it because I just don't see that. That's not my population. We don't have a lot of throwing sport that you have in the States. So we see very little ulnar collateral issues.
Huh. You don't have baseball.
No, we don't have baseball.
But you have that thing where they come running up and they twirl their arm like and then they throw it at these little upright sticks and they have these mallets. What is that? Cricket.
Cricket,
you have cricket.
We have cricket.
See. You twirl and you don't cause the valgus deformity.
No, we don't. And though they do a lot of throwing, they do not do anything like as much throwing as your baseball guys do or your American football players do, because the throwing is only part of the game for them.
Well, that's right. You guys don't have football.
We have football, but you call it soccer.
But we throw spirals. You kick with your feet. Isn't that something? Fascinating. I did not even put that together.
Yeah. But and this was the same patient, but they have quite a thickened sort of middle part of that. This is a common flexor origin, what we call a golfer's elbow.
Yes.
but I often just see small changes in the superficial fibers. This was very strongly thickened in that short axis, in that deep sort of mid aponeurosis.
As a compensation, begging for stability and trying to get trying to help out the other thing. I'm trying to figure out how it got big like that.
I don't know. It's just tendinosis.
Yeah.
That in fact, this may even have been trauma related, but don't quote me on that, because I don't quite recall all the details.
Is that joint fluid at the bottom there? What is that black area?
That's just anisotropy. That's
okay.
Just normal the muscle. Let's see if we've got anything else interesting on this thing. Yeah, this is another thing I don't see quite so much of. And I don't think it's going to be that interesting, so I'm sure it's something it's something I see a lot of. But rarely this soon after it started. Do you recognize it?
Only in that's compartment 1 of the wrist.
Yes, De Quervain's.
Yeah.
But we see a lot of these chronically because they take a long time to get to us in the public health. But what I love is that complex anatomy. It's not one tendon.
Yeah.
The pollicis longus. I think I saw an anatomical example where there were like 10, 14 slips, but you regularly see 3 or 4. And I love the way they grasp they reach over like fingers over the CMC joint, and they help. I'm sure they help to stabilize the CMC joint.
Wow.
Yeah.
They have almost the properties that you see sometimes in the subscapularis as yes. It comes across there.
Yeah, lots of different bits there.
Take me back to the Doppler, John, because is that a vessel underneath it?
Yes.
Okay.
Yeah, that would probably be a branch of the radial.
Wow.
Yeah. Let's see what else we've got. First, the shoulders, problems, and yeah, that's all that. Let's have a look. Oh, again, not something I. When you look at peroneus longus, always looked at it in the side of the ankle. So you follow it. Never really spent, until relatively recently, I never bothered to look at it in the foot itself.
Oh, interesting.
And here it is nicely.
Where the brevis stops at the head of the fifth, and the longus just kind of goes around.
Yeah, and but you actually see it relatively easily in the distal foot.
How do you orient yourself? Do you simply follow and then turn on it as you?
No, it's awful to follow. It's really, really awful to follow. The image quality is so poor along that fat on the side of your foot. It's and it changes direction so rapidly that you really have to really work your parts off to be able to follow it at all, never mind interpret it. So what I do is I spot where it's going round the corner, and I put my probe there, and then I angle distally with the other end of the probe on the sole of the foot. And if you do that, there's only one structure that just cuts right across underneath all the muscle. So you see all the intrinsic muscles.
Yeah. And does it insert on the navicular?
Or the base of it's around the cuneiform, I think, or base of the first. But it has its own. It's a big bulky insertion onto there, and it's so you see it going there with fluid around it. Then you turn around the probe, and there you see it.
You did just fine. You
Yeah.
did.
But
Wow.
it's one of those things that if you'll think it's going to be difficult, and then if you put the probe in the right place, it's actually very easy.
Wow. So this was an overuse issue of Longus, as it was attempting to provide some level of support down there.
If I remember rightly, it may well have had something to do with fluid tracking down from the ankle. I think there was pathology proximally. Sorry, Beth wants to ask whether you eat peanut butter and jam sandwiches.
Yes, we call it peanut butter and jelly, or PB and J. Yes,
Yeah.
we do that.
It's called jam, but
Jam. What is the difference between
jelly
Yes.
is squishy and you can turn it into juice easily by like touching it, basically.
Yeah, jelly is what we call what you sometimes put in a trifle.
You know, John, I miss your sono hacks. You need to come up with 2 or 3 more of them and throw them to your channel, because you know I still use that for so many things. I remember, you know, even the calcaneofibular ligament, where you come around the palmar or the perineals, drop off of it, and that's we need more of those.
Yeah, they take a bit of work.
Yep.
And
and it makes you realize what these guys who have successful channels on YouTube, how much work they've got to go through to do that on a weekly basis. It's insane.
I know it's and you have, and it helps if you're set up for it.
Yeah.
But I know Johnny, who did those, they were they were a lot of work. You know, I just had to do the scanning bit. That was the easy bit. Johnny putting them all together and planning them and things, and it's like, yeah. And I thought, oh, I might have a go at doing a few, and it was just even doing the clips so you can stick them on on what's the name, a tweet. They take 10 or 15 minutes just doing a really short clip, and it's like, really? So yeah, I need to work less. That's the thing.
I hear you.
What is this one? This is something I really don't. I see it called on MRI sometimes. I see it certainly talked about a lot, but I rarely see it convincing in the flesh. And this is a pesanserine bursitis.
Oh, yes,
and
it is.
It's tricky. It wasn't as straightforward to scan as I thought it was going to be, but he had really dilated collection of fluid over his over the anterior medial.
So are you trying to stay on the MCL, or are you trying to follow the hamstrings?
I was following the hamstring.
Gotcha.
So I've got, this is there. This is the which hamstring? This is going to be the sartorius. It has that classic appearance there, the soft, sort of flattish muscle coming down.
I don't have that in my head. I would love to know what you're talking about when you say classic appearance.
Well, it's worth looking at, because just for that orientation, that familiarity. You don't see a lot of pathology, but sartorius, gracilis, and semitendinosis.
Yes,
we're all used to picking out semitendinosis.
Yes.
But if you just scan the medial thighs, you'll pick up sartorius coming across as it's sort of really flattish muscle.
And that's what that is, a quarter of the way down, filling up half the screen there.
Yeah,
the sartorius.
Just this bit down here. Yeah. And it then has a flattish tendon. Well, they're all of them have flattish tendons as they wrap around, and it really does wrap around the front of it goes well past the MCL and comes around in a very curved path.
Wow.
So you see that, and then you'll find once you get your eye into that, you'll pick up gracilis, probably this nub in here, a little bit slightly more distal, and you just get used to following these tendons around. And but yes, I was just interested in catching the shape of the bursa here, so I've not done a particularly good demonstration of that. But that caught me by surprise, because I was fully expecting it to be with the position of it. I thought that's going to be an anterior meniscal cyst, 10 days out of 10. And then no, it was actually coming out from underneath the insertion of underneath the distal fibers of the sartorius.
It has the shape of what I would have initially thought a cyst would have, and so interesting. Yeah.
So this is something that I'm not expert in, because again, we don't see a lot of this, but this is an AC joint, and we don't see I don't look at the sporting population, so I don't see this very often, but there's a lot of movement there.
Yeah.
It's quite unstable.
How did you facilitate that? Did you just do a drop arm, or did you
I just moved the arm around.
Oh, okay.
It's see what it does. I don't do anything very sophisticated. That's
what even made you want to look at it? Was there a gapping?
It was standing up, and you're kind of saying, is this 2 or is this 3? on the old, I can't remember. What was the scale before Rockwood?
Yeah, I don't even know those, John.
Yeah, Rockwood's the scale that people used.
And it was the dimension of clavicle.
Well, it's 1 to 6, and it's about how much displacement there is, or whether it's sticking in the muscle or all sorts. So it's quite a sophisticated one.
Interesting.
It proceeded after a scale that was simple 1 to 3. So 1 was just a little bit of movement, 1 was a lot of movement but not displaced, and 3 was when it was up and had to be treated. That was what I grew up with. Let's have a look. Sorry. Something I do see quite a lot of is undisplaced or relatively undisplaced greater tuberosity fractures. So we see a lot of ones that have either not been seen on X-ray, or this one was seen on X-ray, and they just happened to get an ultrasound scan at the same time. So this is if you've got yourself orientated.
Yeah, I see it. I don't know what to do with these.
I do relatively little. First of all, I try not to inject them if they are relatively recent. So if they're within the first 3 months, I tend to try to convince the patient that actually you want to let nature take its course.
What's the mechanism of the compromise? Is it compression under the acromion? Is it traction of the tendons? Is it direct impact? What?
Direct. I think we go on Shoulder Doc. There's a Shoulder Doc website, and I'm sure he gave a good description of all the various injuries mechanisms for these.
Is he MSK savvy, or is he just information about the glenohumeral joint?
Yeah, he's a shoulder surgeon based up in Len Funk's website, but he's one of the big academic people for shoulders. He's very enthusiastic, and he has a very strong educational website, and he puts up shoulderdoc.co.uk is his site, and he's a pretty good place for the straightforward information just on what's on just about anything that's going on in the shoulderland. But this is the lateral aspect of the greater tuberosity. So the insertion is supraspinatus will be up here, and that's what you see on X-ray in this case. And but what I like is the way you see that disruption.
Yeah.
You can probably see a small evidence of some fracturing there, but not much. And then back at the start, you just see that damage to the surface of the greater tuberosity just as you're coming up the biceps.
Yeah.
Which I've got there. That's good. Right. I think let's see if we can find one more good one, because I think I need to go and help put some children to bed.
Yep. Thank you for your time, John.
Baby sisters, give me there was something else. These are always, this one is, they come in with a lump on their leg, usually painless. And no, that's not it. No, there we go. And I can't see it when I scan it, or I can only get a suspicion of it because I see this break. This is a muscle hernia between, and often between the tibialis anterior and the extensor digitorum. They just appear, there's just sometimes a weakness in the muscle wall there.
Yes.
And but you often can't see it, or it doesn't stand out even when they contract their muscles when they're lying down. When they stand up, it becomes obvious.
Is it a herniation from within that muscle? It's just, it's not being held in by the periosteum? Or
Yeah. Off you go, guys. Off you go, guys. I'll be with you in a minute.
The paramycium or whatever, the wrapping has been compromised, and so it's that very muscle that is extruding.
Yes, I think so. It's really difficult to tell, but you don't get, because sometimes you'll get this and it will be a little lipoma in there.
Yeah.
But in this case, I couldn't see any boundary. The muscle, the integrity of the muscle fiber is difficult to orientate on, but I can't see a boundary.
I can see the fibers that are just extruded that seem to, at least in a certain area, have a breach in the corset of the paramycium. Isn't that something?
And you don't. I don't think you do a lot about it unless it's problematic. But you know, it's good to be able to see it and reassure.